Beautiful. So Dr. Barry Eiden and Dr. Melissa Barnett will speak with us about incorporating technology in today's keratoconus practice. Cool. So we'll go ahead and introduce our speakers here. I don't know how you can fit either of you guys, your bio on one page, but so Dr. Eiden is the president and medical director of North Suburban Vision Consultants and a multi-specialty group practice in the Chicago area. He is the president and co-founder of the International Keratoconus Academy of Eye Care Professionals, which is an organization that provides education and research to eye care professionals. He is also the co-founder and president of IVIS Eye and Vision Research Institute, which is dedicated to clinical research and development of technologies in the eye care field. He's an assistant clinical professor at the University of Illinois at Chicago Medical Center in the Department of Ophthalmology, Cornea and Contact Lens Service, and an adjunct faculty member at Indiana, Illinois, Midwestern, Salus, SUNY, and UMSL Colleges of Optometry. You've seen him publish in numerous editorial professional journals and professional literature. He's also the past chair of the American Optometric Association Cornea and Contact Lens section, along with a fellow of the American Academy of Optometry and Scleral Lens Education Society. And then Dr. Melissa Barnett. Oh, so here are some of his disclosures here. So Dr. Melissa Barnett is a principal optometrist at the University of California, Davis Eye Center in Sacramento and Davis, California. She's an internationally recognized key opinion leader specializing in dry eye, contact lenses, and presbyopia. She lectures globally and publishes extensively on topics including dry eye, anterior segment disease, contact lenses, presbyopia, and creating a healthy balance between work and home life for women in optometry. She's a chair of the American Optometric Association Contact Lens and Cornea Section, a fellow of the American Academy of Optometry, a diplomate of the American Board of Certification in Medical Optometry, and a fellow and global ambassador of the British Contact Lens Association. Serves on the board of the Gas Permeable Lens Institute, International Society of, I just lost my place here. I guess I need to check my prescription. As the past president of the Scleral Lens Education Society, and she's helped author and edit the book Contemporary Scleral Lenses. So we are so excited to hear from you guys, and we've had the honor of hearing from you guys before at WooU, and we know that we have something wonderful in store. So thank you guys so much for joining, and we'll let you take it away from here.
Well, after that introduction, I don't think we have any time for anything else, do we? So I guess we're done.
Drop the mic.
Well, this is a real fun one. We're talking about technology today in today's keratoconus practice, and it's such a pleasure to be here. So happy you're all here, and always a pleasure to lecture with you, Barry. So this is going to be a lot of fun. So we know the prevalence of keratoconus is really increasing because of the way we can diagnose keratoconus. So this very older statistic now, the 1 in 2,000, that has been quoted and said, that's what maybe some of us learned in school. That's what a lot of our colleagues learned from many, many, many years ago, is now outdated. And it's because we have so many different new studies, and it's the way that we can detect keratoconus. So we have this advanced technology that we're going to share with you today. We're also going to share some non-advanced technology that you can use in your practice, because in both of our practices, keratoconus is so highly prevalent, and we want to make sure that in every practice that we're looking for keratoconus all the time. So I actually believe in an eye exam, we should be ruling out, just as every patient we're evaluating for dry eye, we do want to evaluate every single patient for keratoconus. So let's look at some of the other studies. So besides the 1 in 2,000, it depends on where the study was done, looking at the different study populations. Here you can see India and Israel at 2.3%, China 0.9%. If you go down a bit and you look at the study by Chan et al. In 2020 in Australia, that was 1 in 84. And then we have now a very large global meta-analysis that states that keratoconus is even more prevalent, so 1 in 700. but I should probably let Barry speak to this one, but I'm very proud of him and his entire group who did a pediatric prevalence study. And Barry, I'm going to let you take it away because these results
Sure.
are kind of impressive here.
Yeah, so over the past few years, the International Keratoconus Academy, along with Illinois College of Optometry and one of their pediatric eye clinics, ran an analysis of prevalence for keratoconus based on corneal tomography using Pentacam. We ran about 2,300 kids. I mean, they were all of school age population from kindergarten all the way up to the end of high school, predominantly a Black and Hispanic population, almost exclusively, inner city, lower income individuals. Utilizing some of the software from the Pentacam for analysis of abnormal corneas, our initial data showed a 1 in 72 positive rate for abnormal tomography. If you can click the next slide or the next click, you'll see something. Keep going. Thank you. Now, that was based on what's called the Bell and Ambrosio analysis, which is a software really to detect abnormalities of corneas prior to refractive surgery. Not quite specific, very sensitive, but not specific to keratoconus. So in order to make it more specific to keratoconus, you have to add in other values. And we're in the process of analyzing this data. But when our first go through added this final, what we call the D value from the Bell and Ambrosio analysis, with a posterior elevation anomaly, our prevalence actually, which was more specific to the disease keratoconus, was 1 in 320, which is a fairly amazing number in this pediatric population. And to Melissa's point, it really emphasizes the need for us to consider keratoconus in all of our pediatric patients in terms of our suspicion and screening for it. So hopefully this kind of information will push the technologies available to most doctors so they can have sensitive technologies. As you'll see, when we talk about some of the technologies, numbers of them are not available in most practices. We have to make them more available or some sort of modification of these technologies. So, yeah.
Excellent job. Completely agree there that we do want to have these technologies available really in all the practices all over the world, I would say too. So not just in the US and Canada, and but we do want to be able to diagnose and pick up keratoconus sooner rather than later because of the great advantage that we have to stop progression of the disease and preserve vision. Now, not only preserving vision, but helping improve one's quality of life, preventing the need for a corneal transplant down the road. So early detection and being able to stabilize the cornea is critically important. So we have all these different advanced technologies, and we want to try and catch keratoconus prior to it affecting vision at all. So we don't want someone to have advanced state of the disease. We want to be able to pick up the most early and mild forms of keratoconus so that we can stabilize the cornea to prevent progression and to help improve visual function. So we still want to keep in mind all of those red flags, changes in glasses prescriptions, increase in astigmatism, looking at keratometry values if you don't have some of these other technologies in your practice. And here's your call, Barry, that industry really needs to develop, and we all need to work with industry to develop these sensitive tests to put into the hands of everyone, and I'd say all over the world. And it's always really important to note that when we're comparing metrics of the same technology from different manufacturers, it's always like comparing apples and oranges or something like that. So they're not exactly comparable. And I do this all the time, and I'm looking at these values and saying, well, these are completely different. So in my clinic, I actually document what instrument the values are from and document it in the chart, because then in my head, I know, okay, that makes sense for this specific instrument versus another technology. And it could be two different technologies for the same patient, but I do document that. I've been doing that more recently, and I do find that that's helpful when I look back at the charts and just to make sure that everything makes sense. And so the scanning quality matters. Of course, we know this for everything, but really important for keratoconus. So we want good, high quality scans. And I'm always working with my technicians. And some of the instrumentation, they do take a bit of a learning curve. But my technicians, we always need to go over really good quality images. And I would say put the time into training of the staff, because staff is so helpful and wonderful. And when you have good staff who do the measurements for you and you get good data, it's invaluable. So here we're looking at different corneal shape analysis systems. So of course we have corneal topography, which is curvature based. We have corneal tomography, which is elevation based. And then we have anterior segment OCT. So with placido topography systems, these are curvature based corneal shape analysis systems. And perhaps more practices have these. I know that IKA has done some research, and other groups as well, looking at how many practices have different technologies. But here we can have a direct measure of the curvature, and it is a sensitive measure. So it's helpful. It's an affordable option, so maybe a little bit more accessible for some practices. And it can have other functions, which I always think is wonderful, to have multiple functions within one instrument. So we can have, for example, aberrometry, we can have non-invasive dry eye analysis, and this could be something that could be used more widely clinically. And Barry, feel free to chime in if there's anything here that you want to add too.
Totally.
So
no, I think your point was so well taken in terms of topography. Now, I think we're almost a little bit preaching to the choir. I think it's like 1,200 people in the choir. But if I looked at some of the numbers that came from yesterday's talks, when they took a survey, that I believe over 50% of the attendees had corneal topography, and about 15% actually had corneal tomography. Both of those, I think, are significantly higher than the true ECP numbers out there. So we're dealing with a high quality group.
well, what an honor to be able to speak to a high quality group. That's wonderful. So, just looking globally, this group is a little bit more advanced than others. So we have the importance here when we're looking at corneal topography. Again, won't cover this too much because you already have topographers, you're using them in your practice. But we know that symmetry is very important. And when we're looking at keratometry values, or the SIMKs, over 47 or 46, and I'm always looking for change also. So what was it, say if you have a topographer, what was it a year ago? What was it 2 years ago? If you don't have that information, if a patient had, say, corneal topography or tomography done elsewhere, obtaining that information and looking for change over time. We also want to look for symmetry and asymmetry, the inferior and superior. And we also want to look for that skew deviation of 1 diopter and a half of cylinder or axis asymmetry. So these are things that we're always looking for. I find that these images are really helpful for our patients to actually show them the images and show them their eyes. Plus, they're really cool to look at too, right, Barry? Aren't they cool?
Totally cool.
So totally cool. And educational, right? We can educate our patients. This is why we're talking about this, whether it's keratoconus, whether it's refractive surgery, whatever it might be. So that we know that we have many different distributions of patterns, and I'm not really going to go over each of these because I do want to move on to other technologies as well. But the main thing is, if there's asymmetry, if it's not perfectly regular, then we want to be aware and be on the lookout for corneal ectasia, keratoconus, and really any sort of condition. So we're looking here at the corneal indices on your imaging, and we can actually classify keratoconus, and we can use this technology in order to classify keratoconus. So Barry, just curious, because I don't think I've actually asked you this, but in your clinic, in your notes, are you actually classifying keratoconus, or are you grading keratoconus when you're identifying it?
It's a great question, and I'm going to be very honest with you. I have my I wouldn't use it a grading system, but kind of a severity system in my mind. And I talk about that with every patient that I see for their initial consult. And, from my perspective, what I tend to do is kind of rate it on a 0 to 10 scale. And I'll always tell people, and it often is very helpful for them to understand their condition. I will say, listen, your right eye that you're seeing pretty well out of, from the things that I see in clinic, your level of keratoconus on a 0, meaning no keratoconus, to 10, meaning we're taking you out for a transplant later today, you're a 3, really pretty good. Your right eye doesn't see as well. I would grade it as a 6. It's very arbitrary, but you and I know that after enough experience, they're pretty accurate, right? And people always think that they have the worst case of all people with keratoconus, right? They think they are suffering more than anybody in the world. And they really often will tell me that, oh my God, I didn't realize I was doing so well. And that's a good thing to know. And of course, so many come in telling us they've been seen elsewhere and told that, oh, they're going to go blind and they're going to need a transplant. And we know that in the vast majority of cases, that actually is not true. So yeah, I think these softwares are kind of nice, especially when you're dealing with questionable topographies where you're not quite sure, about the anomaly and abnormality. But I don't put too much weight on, their staging, at least for me.
Yep, I completely agree. Sometimes when we have corneal topographies that are a little suspicious, I'd say maybe not 100% keratoconus or cornealoptasia, but they don't look quite regular, then I talk to my patients about just avoiding corneal refractive surgery, monitoring, and we're going to go into some other options like genetic testing that we have as well, enabled in order to pick up keratoconus. So kind of flipping through here, let's talk about the clinical definition of keratoconus. So according to the global consensus on keratoconus and ectatic disease, it is mandatory to measure the posterior cornea and abnormal posterior ectasia. And I always feel like I'm cheating when I'm measuring the posterior cornea. It's like, oh, look, you can see it's keratoconus right there. But I also feel very lucky to have this technology in our practice. Also in this definition, an abnormal corneal thickness distribution and clinically non-inflammatory corneal thinning. So what about some of your practices that might not have this fancy instrumentation? What can you use? You can use your standard instruments. So here, and I would encourage you to do this, even if you are doing all the other testing as well with your diagnostic instruments. So be thinking, if there's vision that you're refracting, it's 20/20, but it's not a clear 20/20. It's kind of a wishy-washy 20/20. If a patient comes in and they say that their vision is blurry, their vision is fluctuating, it's changing, their shadows, the double vision, right? And I always ask, is that overlapping double or is it two distinct double images? Poor quality of vision, and use the tools that you have. So we want to be just looking at what is their refractive error now? What was it before? Is there an increase in astigmatism in one eye or both eyes? Is there asymmetry in astigmatism between the two eyes? Are glasses and contact lenses just changing all the time? Is it a simple increase in myopia or an increase in astigmatism or both? And always looking at keratometry. So even if you don't have advanced imaging, you could use a standard keratometer, you could use an auto keratometer and look for irregular Myers. And I've actually trained my staff to do this so they can tell me, you know what, this one doesn't look quite right. And then I go back and look at it again. And of course, we could use corneal topography and tomography. So here you can see the irregular Myers when you're doing keratometry, just looking for steeper Ks over 47 or so. And here's a kind of a nice study looking at retinoscopy and showing that retinoscopy actually compared to corneal tomography was very, very sensitive and very specific. So sensitivity of over 97%, almost 80% specific. And here you can see really nice image looking at retinoscopy. This is thanks to Lynette Johns through a scleral lens showing that scissors reflex. So pull up that retinoscope, use it in addition to the other tools that you have as well.
Listen, I want to add or go back to one of the points that you brought out before, which I thought was really important. You had that slide that indicated not correctable to 2020. Do you remember that? So
Yep.
It's a point I want to bring out to a lot of folks. And that is, yeah, the one on the bottom. So I think especially unilaterally, and I've seen this in many cases, unfortunately, where a patient, especially a young patient, is not correctable to 2020 in one of the eyes. Let's say it's 2025 or 2030, and they make a diagnosis of amblyopia. Now, it's so important, and again, I'm probably preaching to the choir, to realize that to use a diagnosis of amblyopia, you have to have a reason for amblyopia, either a constant strabismus or significant anisometropia, something like that, or even an ocular, a retinal disease that can account for it. But if you don't have any sort of ocular misalignment, you don't have significant anisometropia, and everything else looks normal, pupils are normal, color vision is normal, man, start looking for keratoconus. It's one of the differential diagnoses, and just don't blow it off to amblyopia. I think it's just too easy to use that term, and it should be used properly. So that's just my 2 cents on that topic.
Yeah, I think that's a great point, but really for anyone, that any condition. So not just when we're talking about corneal conditions, but if someone's not 20/20, we do need to evaluate why. Is it a congenital cataract? Is it diabetic retinopathy? Like, what is it where the patient is not 20/20, and really, dive in a little bit more. But that's a great point, Barry. Especially comes up a lot for keratoconus.
Okay, you want me to take over here?
Yeah, it's all yours now.
Cool. Okay, so we're going to just keep moving along further, and we're going to say to ourselves, what is it? Topography is a great tool, fantastic tool. Again, it's going to be sensitive once it affects the anterior cornea. So in terms of keratoconus, if the anterior corneal shape is affected and curvature is affected, it's going to show up on placido topography. But there are limitations to this technology, especially when it comes to keratoconus. Number one, that it doesn't analyze the back surface of the cornea. And number two, that it doesn't represent corneal thickness. And as we were talking before, Melissa mentioned the global consensus paper, that seminal paper on diagnosis and management of keratoconus and corneal ectasia. In order to specifically say you have keratoconus, you must have an abnormality on the back surface of the cornea, and you have to have an abnormality of corneal thickness distribution. That term distribution is the key word. We can go to the next slide, I think. Yeah, so posterior corneal shape has to be measured, and you have to be able to measure the entirety of the corneal thickness, because using just the thin point or the central pachymetry point, that is not at all specific to keratoconus, as we'll see that in a couple of seconds with an example. But corneal thickness distribution, which really means the change in corneal thickness from the thin point out to the periphery, is anomalous in keratoconus in all cases. So in order to be specific to keratoconus, you have to measure the posterior corneal shape for an anomaly there, typically an elevation, and an abnormality of corneal thickness distribution. So the how is corneal tomography. The how not is corneal topography. So I'm not saying that we should all get rid of our topographers, for sure not, but we have to realize that they are limited. We can get significant numbers or cases of false positives where we think it's keratoconus, but it isn't. And we can get cases of false negatives where we think it isn't keratoconus, but it actually is. So this is very important to keep in mind as we go forward. And that's why today for corneal refractive surgery, one is required to do corneal tomography. Results from topography are not sufficient as a pre-determinant before refractive surgery. Next slide. So there are a lot of things. When we're talking about tomography, we can talk about two general kinds of technologies, one being Scheimpflug imaging, things like the Pentacam, and then anterior segment OCT, optical coherence tomography. So all of these tomographies basically take two-dimensional slices to create, in essence, a three-dimensional reconstruct of a surface and of a structure. So we're able to get those key metrics, posterior corneal shape, global corneal thickness, as well as anterior corneal shape and curvature. There are two main technologies, as I mentioned, Scheimpflug imaging and anterior segment OCT. For sure, when we're talking about software developed for differential diagnosis of corneal ectasia, Scheimpflug tomography is far ahead of anterior segment OCT, but I've always kind of felt that that's a missing piece in OCT. It's not so much the technology, it's the software that's been developed for differential diagnosis. So in both of these, we're actually measuring elevation directly. We're not basically inferring elevation from curvature like you do with topography. So all of you who utilize corneal topographers can click on the elevation map, but that's not true elevation data. That is, calculated from curvature, which has its limitations. So we have numerous points of interest that we can measure with tomography. We can measure anterior surface curvature and elevation, and we have anomalies, like cutoffs, and that is definitely instrument dependent. There's no question about it. These cutoffs are geared a little bit towards Pentacam. Posterior elevation anomalies over 20 microns. Corneal thickness, again, using a thin point value or a central corneal thickness value is not very specific to keratoconus. It's that change in thickness from center to periphery that really is a differential diagnostic aspect. And with anterior segment tomography, we are able to measure the epithelial thickness of the cornea specific to those epithelial cells. And what you'll see there is typically an apical thinning of the epithelium with a surrounding thickening in keratoconus, which is classic and is descriptive of epithelial thickness abnormalities in keratoconus in what's called a donut pattern. Next slide. So let's talk a little bit about Scheimpflug tomography. So it uses a principle called Scheimpflug imaging. It's been around since basically the late 1800s. It's a photographic method, but this photographic technology is, of course, digitized, incorporated for computer analysis in the instruments. And again, it achieves true elevation measurements, giving us the front, back of cornea, as well as corneal thickness across the cornea. Next. Again, the Scheimpflug, basically what the Scheimpflug imaging technology will do is it expands the depth of focus. So we can get this image from the front of the cornea, actually all the way into the crystalline lens. So although we're concentrating on the results from the cornea in using Scheimpflug-based tomography, you can also get information about the anterior chamber angle, anterior chamber depth, iris contours, and even cataract changes, lenticular changes you can actually quantify. Next. Here's an image from one of these slices from a pentacam of a keratoconic patient with an apical scar. So one can see this as being sort of like an anterior segment OCT image. The resolution is not quite as wonderful. Undoubtedly, anterior segment OCT gives amazingly high resolution, but one can assess angles. One can look at so many different things as well as the cornea. Next. And elevation, we keep talking about elevation. That's a key element. When you're looking at the maps, these are color maps just like for curvature, but typically the color reference is warmer colors are more anterior in the eye, cooler colors are more posterior. And all elevation maps are calculated against a reference surface. And the reference surface is usually derived from that patient's eye to come up with what we usually use is something called a reference sphere. So in the elevation maps, we'll kind of see what parts of the cornea are pushing more anterior, typically the apex of the cone, both on the front and back of the cornea. We can go next. So here's a normal classic 4-map refractive display from Pentacam. And what you'll usually see in these is in the upper left cornea, and you can move these around, but typically the way we show them is upper left corner is anterior curvature. Upper right corner is typically anterior corneal elevation relative to the reference sphere in microns. So those numbers are how far they're either positive values are anterior, negative values are posterior compared to the reference sphere. And lower right is elevation on the back surface of the cornea, and lower left is global corneal thickness in microns, as you can see. Okay, so let's go to the next one and see the difference to a keratoconic eye. As you can see, dramatically different. As we say to the patients when I'll show them their maps, it's going to get very colorful in your case. You'll see lots of colors, not necessarily good, but at least it's colorful. So again, you can see the upper left, that curvature map, which is very similar to your classic Placido topography maps. Those are corneal curvature. And you can see that steep portion down inferiorly. Look now at the elevation maps, the upper right and the lower right, and you'll see the apex of the cornea being the hottest color where those arrows are pointing to. Two things to notice. Number one is the fact that the value and color in terms of how red it is greater on the back of the cornea than the front of the cornea. What does that really mean? We all know the back of the cornea is pushed forward more than the front of the cornea. Well, what happens? That's where it's going to get thin. If the back is pushed forward more than the front, it's going to be thin. So you're going to get a coincidental positioning of the maximum elevation on the front, back, and thin point of the cornea. And you can see that in this example, they're basically at the same area. The other thing I wanted to mention was look at the front elevation maximum and look at the steepest portion of the cornea on the axial map. And you'll see they're not at the same position. Why? Because they're not measuring the same thing. If you want to know where the top of the cone is, then you look at the elevation map, obviously. But if you want to know the steepest curvature, you look at the curvature map. So the analogy I often use is like a saddle for a horse, right? So the top where you put your butt, right? That's the most elevated portion, but it's not the steepest portion. The steepest portion is down lower in the saddle. And so a lot of people think when you're just looking at curvature maps, oh, if I put my rigid corneal contact lens, it's going to center over that because usually these lenses center over the apex. Well, they do, but the apex is not the steepest portion of the cornea most often. So just a point to bring out. We'll go to the next slide.
Oh, just before we go to the next slide,
Yeah.
just going over a few things. So for those who don't have this instrumentation, some values that I'm always looking at, and to help also with checking a refraction prior to, say, a contact lens fitting or just as a baseline. So we're looking at the amount of astigmatism. So here you can see in the normal cornea, 0.7. And I'm not saying that this is definitely what you're going to get on refraction, but compared to the patient with keratoconus here, where we have 6.4 diopters of astigmatism. So you could see that huge change. And then also going back just one more thing, when we're looking at the corneal thickness, say on the pupil center here on the normal cornea of 530, and then on the patient with keratoconus here, going to 476, so much thinner. So those are all values that we're looking at when we're analyzing these scans.
For sure. And also another point I'd like to bring out, if you go back one more, I'm sorry. If you go back one more, if you look at the axial map, whether it's on tomography or corneal Placido topography, what I often will do when I look at these maps, I'll look within the pupil zone, and you can see it outlined in those little areas. And I look at the pattern that's within that visual zone. How regular is it there? There are so many keratoconics that are very irregular outside of that, but rather regular astigmatism within. This one is kind of non-orthogonal. You can see that kind of skewed axis to it, but a lot of them are not. And when they're not, they're fairly regular. I'm expecting, if there's no opacities in the visual system and everything else is normal retina and optic nerve wise, I'm expecting to refract them to a decent level of vision. So I get my refractive expectations from looking at the axial map within the pupil zone.
Good point. And having a refraction is really good to determine what is the best corrected vision with the standard refraction. Is it 20/25 or is it 2200? And so this is something that can guide us. And when we work with specialty contact lenses, the setting expectations is very important, and using that refractive error helps guide those expectations.
So they say, kind of like the statement is, everything's on the backside in keratoconus. Bottom line, as I mentioned before, in order for us to differentially diagnose an irregular cornea from a keratoconic irregular cornea, you must have a posterior elevation anomaly. And in every case that I've ever seen in all my 18 years of doing this, the posterior elevation is always more advanced than the anterior elevation, and that's how you get localized thinning, whether you measure it with Scheimpflug or with anterior segment OCT. Next. So here are examples of corneal thickness distribution, okay? We see the back surface map, but if you look up to the right, you see how you're measuring that distribution. Basically, what it's doing is taking these concentric rings, averaging thickness as you go from the center out to the periphery. And what you end up developing are two kinds of maps, which you see in the lower screen. The top one, which is called the spatial profile, the thickness spatial profile, is absolute thickness from the center to the periphery. The normative database, the middle line is the mean, and then you have two standard deviations above and below. But the real sensitive one is that one below, and that is the PTI, a percentage thickness increase. That tells you about corneal thickness distribution, or the rate of change of corneal thickness from the center to periphery where it thickens. So in keratoconus, it always thickens much quicker than a normal cornea. As you can see in this example, it's definitively keratoconic, that it is abnormal in the PTI, the one on the bottom, but look at the top one. It's totally normal. It's within the normal range. And here's a case where you have the thin point of the cornea that is quite normal in this case in a definitive keratoconic patient, that you can tell from the elevation anomalies and the global thickness distribution. So next we go. Okay, so again, the fact that in the global consensus paper, they stated that central corneal pachymetry findings from a diagnostic standpoint is one of the least reliable indicators or determinants of keratoconus presence. This is because you can have normal corneal thickness in the center or even at the thin point and have keratoconus, but it also works the other way. You could have pretty thin central cornea and not be keratoconic. So we'll see examples of that. We can go to next. And again, here's that example of normal central corneal thickness in the 500s micron wise, but look at the change of thickness from center to periphery, it's abnormal. And if you look at the curvature, the elevation values and such, they are definitively not advanced keratoconus, but definitely keratoconic in a case of normal central corneal thickness. Next. A number of ways to look at this. So you can see up top where it says false negative on Placido, this is a case where the front surface corneal curvature and elevation are both normal, but the posterior corneal elevation and in fact the corneal thickness distribution is abnormal. This may be a form of early keratoconus. It could be an abortive case where it just reached this point. This patient is going to have, for the most part, normal corrected vision. They may have an ametropia, but they should be correctable to a very good level of vision. Yeah, the back surface of the cornea, as you'll see in a little bit, may induce some hiatal aberrations, but for the most part, this patient will see pretty well. Down below that, again, that's the example we showed you before of normal central corneal thickness, but abnormal thickness distribution. And then to the right is where you can get a false positive on Placido. If you just look at the curvature value, which in this case is the upper right, you have that inferior steepening. And the steepening is relatively steep. You see numbers that are encroaching on 50 diopters. But if you look at the elevation maps, they're quite normal. The maximum elevation values are within the normal range. And corneal thickness, I didn't show you its distribution, but the corneal thickness distribution is normal in this case. One thing I want to mention here, you see all these corneal thicknesses of 600 microns. You say, well, of course, that can't be keratoconic. That's not true either, by the way. I can tell you from a case I just saw maybe about a week ago in follow-up. It's one of my patients who has keratoconus and and also a endothelial dystrophy. And that patient actually has relatively thick corneas, but keratoconic elevations and keratoconic thickness distributions, a combination of two. So just because you have a thin point of 600 plus microns, even though it's rare, doesn't mean you can't have keratoconus. Next slide.
So patients can have more than one thing on the cornea?
Yeah, I think they're allowed. I think they're allowed up to 3, Melissa.
Okay.
After that, no, you can't have
No, got it.
So anterior segment OCT, again, one of the great things about anterior segment OCT is we all know who utilize it, the exquisite imaging quality, the high resolution. You can see such tremendous detail. It also can provide global pachymetry. And also we can see that we can measure epithelial thickness as well. Now, if you look upper right, you see all of these kind of values. These have come from some papers that have been published in looking at quantifying and using software analysis of corneal thickness from anterior segment OCT. Unfortunately, so far in commercially available systems, these kind of software analyses are not available. I'm hoping that manufacturers will put the time and effort in, because I'm going to be honest with you, a whole load more people in eye care have OCTs than have Scheinflug-based imaging systems. So I'm hoping that someday they'll use the information they have at their fingertips here and just get the software developed. If you look below, that's epithelial thickness measurements, and also a nice way to look for early keratoconus. And you can see this is a little bit more of an advanced keratoconus. The right image where you see that orange and then the deep blue, that's kind of that donut pattern I was telling you about in terms of epithelial thickness, where over the apex of the cone you get thinning, and around the periphery you get thickening of that epithelial thickness map. So what you're really looking for in ETM maps in keratoconus is variability, not the average. Because if you actually look at keratoconics, their average epithelial thickness is just slightly thinner than the normal population, but it's their variability or variation along the surface of the cornea and epithelial thickness that differentiates them and pattern. Next. So now I think we're going to you, Melissa.
Yeah, so we're moving on here. That was great, Barry. So much wonderful information. Just one thing to add, because we know that global pachymetry is so important, and also that measuring the posterior cornea is important. If you don't have this instrumentation, it's a wonderful way to collaborate with others that do. So if you have a patient where you do want this imaging, definitely work with someone else in your community, send them for the imaging, get it back. But that's a great way to send referrals. So within optometry, to ophthalmology, corneal specialists, whatever it might be. But we want to do what's best for the patient. So we do want to obtain the imaging, even if it's not in your practice. And hopefully we will have ways in the near future for everyone to have this technology in your practice. So moving on, we are going to talk about scleroprofilometry, which has been, just so much fun. And we talked about different ways of measuring corneal scleral shape. So we have the anterior segment OCT. We have corneal tomography. We also have advanced ways of taking impressions of the ocular surface, such as eye print, to measure as well. So here we have our anterior segment OCT, which can tell us so much wonderful information when we're talking about keratoconus and when we're fitting scleral lenses. So we can use all of these technologies, and I know that both of us do in our practices. So using, say, corneal tomography, then using anterior segment OCT, using scleroprofilometry or impression-based technology in order to design different lenses. So it's really helpful to have a variety of instruments in our practices, really to do what's best for our
I'm going to jump in for a second,
yeah,
Melissa, here, just
throwing
the gauntlet to industry again, just like I did. I'm kind of hammering our OCT companies. Just like the analysis of the cornea in differential diagnosis of keratoconus, when they have the data available but not the software, these abilities to design, measure corneal scleral shape, and then ultimately design scleral lenses off of anterior segment OCT, again, these guys had to do it themselves. They figured out their own little nomograms, guys like, Greg Gamarulis and others. But it's not standardized software in the instruments like is available in some of the others you're going to talk about, but it could be. So let's throw that gauntlet out there, guys. And those of you in the industry, start helping us out.
Good. Always good to put a plug in there. So talking about scleroprofilometry, we have 3 different instruments that are now available. We have Eaglet Eye ESP, we have the Visionary Optics SNAP 3D, and then we have the Oculus Pentacam SCSP. So these are really helpful to measure not only the cornea, but going way beyond the cornea to gather many more data points. So say 500,000 data points in order to design lenses, and not just scleral lenses. I would say we can design other types of lenses from this instrumentation. So we can scan way out there, and there are some other technologies, but these can go up to 22 millimeters. And really, it's so impressive on how much more information we can get from the ocular surface. I will say another great way to educate patients too. So showing them their corneal images, showing them their scleroprofilometry images, they're cool again, Barry. They're cool, but they're really impressive and they give so much data. So it's helpful when we're talking about designing a specific lens and how it's a highly customized lens, and actually showing the different areas of their eye that can be different. And of course, we can design scleral lenses with huge webs or tubes or pterygium or whatever it might be. So any sort of conjunctival elevation. So when we're talking about the SNAP 3D, images are taken in primary gaze. It's a reflection-based image. Fluorescein is needed. We have many different parameters. All of these I would say are very accurate. So this one here, accuracy in the cornea, 2 microns, sclera 10 microns. And this instrumentation can really be used with any sort of scleral lens, but it is used directly from its specific lenses from the specific lab. So here we have the Eaglet Eye ESP. This lens can directly connect with different manufacturers. And this is just one image of many. So we do have and I think that, never mind, this is Eaglet Eye ESP. I'm like, that doesn't make any sense. So sorry, this one here, I'm talking about Eaglet, where we can connect from 40 lenses to 18 labs. Here you can see the Eaglet. Now we're going to move on to the SMAP, where we have the 3 different images. The images are stitched together. And with this specific company, a few different lenses can work directly with the lab, but any specific lens can be designed with this instrumentation. And just ignore the top part here, but this is the SMAP. And then we move on to the Pentacam here. So in primary gaze, no fluorescein is needed for this instrumentation. We do get all of the regular Pentacam images as well. So we get all of the information that Barry was talking about before. And we can get additional information on the corneal scleral profile, which can give us a lot of different more information. So here you can see an example of the wave technology that can be used, the software that can be used in addition to design specific highly customized scleral lenses. And we also have impression-based technologies. So now we have the iPrint Pro, and as many of you know, scleral lenses were the first type of contact lens that were introduced many years ago with impression-based technology. And we have this technology that can be taken, so we can take a mold of the eye. We have 5 million data points. The image is scanned. We do have different types of lenses that we can design with this sort of technology. And it could, I tell my patients it is the most customized option that we have at this time. So no anesthetic is needed. We have within 2 microns of accuracy and a highly customized option.
Okay.
Moving on to aberrometry.
Yeah, so we've been talking now predominantly about corneal structure. Now we're going to talk about visual function a little bit more. They are obviously interrelated significantly. As we all know, beyond acuity, there's so much more going on in keratoconus visually that affects patients' performance. Next. Next slide. There we go. So low order versus high order. Many of you, if probably, since we're talking to a lot of people, might have been on a webinar myself and John Gillies did last week for the Scleral Lens Society, purely on aberrometry and contact lens correction of high order aberrations. If you were on that, you can see a few of the slides that we used that evening. So we all have been measuring low order aberrations of defocus, meaning spherical error, as well as astigmatism. Measure that with your phoropter standard refraction. But we all know that there's a lot more going on. 10+% of normal eyes function are from high order aberrations, not to indicate that high order aberrations don't affect normal eyes. They do, but not to the degree of keratoconic eyes. And it's only been relatively recently that technology has been available clinically in our offices where we can quantify and diagnose and evaluate these high order aberrations with aberrometers that are clinically applicable. Many of them, you can go to the next slide, many of them are able to do multiple things, just like Melissa was talking about with topography, because they utilize placido topography to help differentiate anterior corneal versus internal high order aberrations as such. So a high order aberration is in essence any refractive error that can't be corrected by spherocylindrical lens combinations, the common ones, coma, trefoil, spherical aberration. Next. So here's an example of a patient with really phenomenal vision. We can see that their low order aberrations are extremely low. Just look at that refractive error, which is almost nothing, 20/10 uncorrected vision, but no high order aberrations. Next. We can see next in the next slide, a case where we're going to see a patient that has refractive error, but really good quality optics. So this kind of patient, once we put the proper refractive correction in front of their eyes, glasses or standard contacts, you're going to end up getting really high quality vision because their high order aberrations are very low. Compare that to a keratoconic patient on the next slide. And we can see both low and high order aberrations are significantly elevated. And that is why these patients really can't see well in glasses, because their high order aberrations are still not being addressed. Next. Now, we know that there are a variety of terms. We won't dive too deep in here. Root mean square, just to make it nice and easy, it basically is a quantification of high order aberrations. It just kind of combines all the high order aberrations into one number, so we could say, do we have a lot of high order aberrations or do we not? So you get an RMS value. Point spread function is pictorial representation. This is another example of what Melissa was hammering home to us before, the educational value of a lot of these instruments to show the patient. The more educated and more aware your patients are, the more compliant they're going to be with whatever management plan we put into place. Next slide. There's this point spread functions below, as you can see on the left, almost a point of light. That's very high quality vision with very minimal high order aberrations. In the middle, you see this vertical kind of elongation. That's vertical coma, very common in keratoconus. And the one on the right is a very complex combination of multiple high order aberrations, very poor quality vision there. Now we can see here in integrated aberrometry, if you are able to get overall aberrometry for high order aberrations and then calculate what the anterior corneal aberrations are through the placido image, you're going to be able to kind of make a separation. So on the top, you can see the three different point spread functions. This happens to be a patient that has elevated high order aberrations, total, anterior corneal in the middle, and internal. What does internal mean? Internal means the back surface of the cornea, as well as potentially any lenticular changes as well. Next slide. Those elevated. And this is that patient just separated. So you can see in the top scan the total hiatal aberrations, the anterior corneal, the internal, but now we put a scleral lens on the patient's eye. That's the below. Look what it did to the anterior corneal hiatal aberrations. Eliminated them basically, but there was still residual hiatal aberrations, as you can see in the total point spread function. Why? That comes from potentially the posterior cornea in a young person. It could be a combination of posterior cornea and cataract changes in an older person who's developing cataracts, but yet is keratoconic. Next. So here's an example, again, of what we call offset. Now, we can see the anterior corneal vertical coma. The internal goes inferiorly. Put them together, and the total is better than each of the components. You see, if you look at that point spread function, it looks better on the total on the left than the center or the right. And the numerics will actually explain that. Now we put a, go back once. There we go. We put a scleral lens on that eye, and look what happened. We screwed them up. They're worse off having that scleral lens than not having it on. So these are the kind of patients that you got to be careful about, because you may not be helping them. You say, oh, I have this wonderful thing for your keratoconus. I'm going to put on this great scleral lens. We fit it perfectly. We've eliminated the anterior corneal hiatal aberrations, but guess what? The internal posterior corneal aberrations come right through, and the patient actually was seeing better out of glasses quality-wise or a draping soft lens. So that's why we use our initial aberrometry, our integrated aberrometry, to kind of predict this, but you surely can find out by repeating it with the lens on. So we can go to the next slide. Now, here's an example of how we can address residual hiatal aberrations. Relatively recently, over the last year or so, technologies have been developed, commercially available, where we can fit a scleral lens, measure residual hiatal aberrations with that lens on, as you can see here in those maps, and then through proprietary software, develop a optical array to be created on the front of the lens to offset the majority of those residual hiatal aberrations. Now, this requires a very stable lens, a lens that is not moving around, a lens that's not rotating. It's very, very stable. And it can only, at this point, be applied to a few different types of designs that are commercially available. One of them actually being the iPrint Pro. And because it's based on so many data points, there probably is not a lens out there that can fit more stably than that. We can go to the next slide. In the same case, this is the aberrometry over the scleral lens. And we could see there's significant residual hiatal aberrations, in this particular case, predominantly coma. Now we then fit the lens properly, and we apply the information to correct the residual hiatal aberrations. Look at the RMS here, 1.46 microns total RMS of hiatal aberrations. Next slide will be the corrected lens. Look at the more even pattern, the reduction on the Zernicke plots, and the reduction in the hiatal aberration RMS down to 0.72, about a 50% reduction. We're seeing, and John Gelles can report on this because he and Stephen have done some actual analysis of their data. And basically they're showing, and I confirm it clinically, anywhere between a 40 to 60% reduction in hiatal aberrations, sometimes a little greater, sometimes a little less, but that's kind of the range. And that is actually clinically significant and subjectively appreciated by patients. So we can go to the next slide.
So real quick, touching on keratoconus genetics, we know that keratoconus is a very complex condition, and I don't expect you to memorize all of the genes associated with keratoconus, but I do want to bring this to note. This was published last year. And we do all now have a genetic test for keratoconus. It is called Avogen. It's a polygenic test, so it tests a range of different levels. And it also is a test for corneal dystrophy. So that's a monogenic yes or no for that. So this is how the test looks. There's a keratoconus risk assessment, and like Barry's risk level of, or rate or level of keratoconus from 1 to 10, here we have a level of 0, no risk, to 100, meaning definitely keratoconus. So this is extremely helpful if there's a family history of keratoconus, if there's some of those red flags, refractive error changes not corrected to 2020, sort of iffy, not 100% corneal ectasia on corneal tomography. But we do have this risk assessment that we can use in order to guide our treatment strategy. So that might be corneal collagen cross-linking to stabilize the cornea. That could be, if it's a very low risk, monitoring with time. If it's, extremely high risk and in a younger patient, because we know that keratoconus does progress more rapidly in those who are younger, we might just go to cross-linking much earlier. So this is a very helpful tool that we have that is fairly new, that we can use in conjunction with our other tools. Again, it's a tool in the toolbox. So we're not just using one thing when we're diagnosing keratoconus. We're using a lot of these different technologies together in order to diagnose and also manage the condition. So this is a very easy test to do. It's done on the cheek. It's a cheek swab. The data is sent off to the lab. It's received back in about 2 weeks. It's really nice that there are genetic counselors that can help as well with both the doctor and the patient in order to go over all the specific genes.
So this is actually a case, both, by the way, Melissa and I have been working with Avellino on this test for numbers of years. We actually, early on, before they were FDA approved, they collected a bunch of samples from our keratoconic patients into their database. And it's been wonderful that over the last year or so, they've really come out clinically, because we're really incorporating it in our practice. And we wanted to share this one really, I think, interesting case from our practice. So we have a patient who is definitively keratoconic, young man, and 15 years old, one of our patients. And because we talk about family history and the importance of ruling out a keratoconus in, siblings or offspring, this particular young man had a fraternal twin, a sister. But again, obviously a fraternal twin. And we spoke to the folks and we said, we really should run some genetic testing and do a clinical assessment. So they were open-minded to that. They brought the young lady in. Her manifest refraction did not show a lot of anisometropia, did not show a lot of astigmatism, and she was correctable to an excellent level of 20/20 vision. However, when we ran Penacam, she did have thin corneas. We'll go to the next slide. Now, this is the brother with definitive keratoconus, right eye and left eye. And you can see that the maps are unquestionably keratoconic. Let's go to the next slide of his sister. And what's really interesting is the fact that in her tomography, anterior corneal shape was normal. The corneal distribution, or the rate of change, that PTI, was very borderline. And we can see through this Bellin-Ambrosio analysis, overall D risk for abnormality is considered suspicious. It's over 2 standard deviations from the mean. So we have a thin cornea, a borderline abnormality of progression, a general assessment of borderline risk. So let's see what her genetic test showed. Next slide. So we ran the Avellino test. Slowly we ran it. And lo and behold, she comes out on that scale of 0 to 100 with a moderate genetic risk for keratoconus. Okay. And so this is a patient, especially at her age, with that family history, with this genetic risk, and with that kind of borderline suspicious tomography. We have to watch her very, very carefully. So our recommendation, at least for the first year or two, is we're bringing her back every quarter, and we're running both tomography as well as anterior segment tomography using epithelial thickness maps. And we've kind of predicted that if she stays normal for a couple of years, we might go to 6 months for a number of years, and then ultimately annually. Here's the point. What happens now in a young person that we diagnose potential early keratoconus? Well, we know that FDA-approved corneal cross-linking requires documentation of progression. It's for progressive keratoconus. However, studies are out there that have been reported looking at the natural history of keratoconic in young individuals. And one of the real seminal studies showed that close to 90% of individuals of young age will progress in their keratoconus. So those particular authors stated that they did not believe that you should wait for progression to do cross-linking in these young, high-risk individuals. And I can tell you that as technologies continue to develop with less risk, meaning forms of cross-linking that have a lower rate of complications, less risk for any kind of complications, I believe we're going to see a day not too soon where for those who are at high relative risk, we're going to prophylactically treat these patients before we document progression, just at the earliest phase of diagnosis. So we'll see what happens, but I'm fairly confident that's going to end up being standard of care. It is not right now.
All right,
just I completely agree. One sentence to add is that the studies demonstrate that females who are pregnant and go through childbirth tend to progress in keratoconus. So it's a point to look out in that population to cross-link early as well.
All right, guys. Well, thank you so much for your presentation and enlightening us on all of the latest and greatest technology for keratoconus care.